Hi friends, welcome to Haemostasis and Thrombosis. I am Lily, I'm one of the third years. I'm currently at the Alfred, and here are my details. You can feel free to message me on my email or just send me a Facebook message, whichever's easier for you, and just some sources that I've used. I really would recommend PS Pup and PS Pingu. Go through their slides, watch their videos. They've got really great notes, and I actually used them a lot last year. Sorry, let me just move this around. This is actually quite an important topic in terms of, big picture. When you become a doctor, you're going to be dealing with lots of actually the medication that works on this cycle. There's probably some things that you'll probably end up learning long term. They're not necessarily going to be very important, but I'll make sure I stress the important things. And I would recommend I think, knowing the broad picture and then focusing on the coagulation studies and then the drugs. And I'll go into the important things I think that you should remember. Just a quick overview of what we're actually going to be talking about, and also actually how once you get a cut, your body essentially stops this cut or whatever trauma you had, stops the bleeding, kind of stabilizes it so that you're not going to spontaneously bleed again. And then also what's really important is breaking down that clot, or that making sure that we don't have a clot just chilling around your body, and also making sure that we don't have too much of the ability to clot and too much of the ability to bleed. So kind of that fine balance between bleeding and stopping the bleeding. The key players, I guess, in this game are your endothelium, so the actual trauma or whatever, the blood vessel itself, the platelets, which we know come off our megakaryocytes, and also our coagulation cascade proteins. Most of these are made in the liver, and they essentially activate one, the other. I think you might have done a bit of this also in year one, and form the clot, and they also help break down the clot. But we'll go all into this. Here is a overview of hemostasis, and essentially, whilst in this picture it looks very much like this happens, or we even teach it, like vasoconstriction happens, your platelets are then activated, this initiates the coagulation cascade, we then have a blood clot, and eventually it breaks down. It's not necessarily as linear as this is, but much easier to think of it as it is linear, of it being linear, sorry, and also kind of being able to separate the things in the processes in your head, which will further assist in understanding the of like antiplatelets, anticoags. But I'll essentially talk us through this in the next couple of slides. So first things first, we have our damage to our vascular supply or whatever, which actually causes or initiates the bleeding. So this could be trauma, it's the classic, you cut yourself. And the first kind of step is you're going to have that reflex of your actual smooth muscle within the blood vessels constricting, which is going to kind of bring the edges of a cut together, and also try increase the ability, decrease the lumen size, so that these factors within your blood and the platelets can stick to the injury and kind of begin this process. So once we have that vasoconstriction of the blood supply, we have the damaged blood vessels. So, the exposure of the subendothelial matrix, which is below the endothelium. And you can imagine usually this is covered by endothelium, so it's not actually very often exposed. So when it is exposed, it kind of initiates a lots of things to happen. So one of the main I'll introduce us to our two main players of primary hemostasis, which is your von Willebrand's factor, which is essentially a really large protein that flows around in your blood. And as we'll see, it helps with platelet adhesion to these sites of injury, but it also has a really important job of carrying factor 8. Again, we'll touch on factor 8 in a bit, to the actual site of injury. So we have the exposure of the subendothelial matrix. From here, you have your von Willebrand's factor, which comes to the site of injury, as well as your platelets, which also come to the site of injury. They begin binding and activating to this subendothelial matrix. And the kind of key enzymes part of the platelets are your thromboxane A2 and your ADP, so your adenosine diphosphate. And these are important in our antiplatelet drugs, which we'll touch on later. But essentially, you've got kind of these things coming to this site of injury. And once they start coming to there, they activate each other. That then activates more. And we end up with a primary platelet plug. So you can imagine this as maybe someone holding a towel to something that's bleeding. It's going to stop the bleeding, but it's not a very good long-term solution, so to say. So then that's where we have our thrombosis, which is the formation of that kind of formalized fibrin plug, which instead of someone just holding something, a towel to bleeding, they're kind of cementing it over, they're stopping the bleeding from continuing. And it's more of a kind of formalized process. In italics, I just have coagulation cascade. Essentially have all these to fibrinogen to fibrin. You essentially have all these proteins, we'll get to in a bit. And the main job that they all have is they activate one, then act each other, whatever. The main thing is that we just turn our fibrinogen into fibrin. And fibrin is actually just activated fibrinogen. So the main players in this thrombosis, there are coagulation cascade factors, which here we have them. There's a lot going on here. We'll walk through this as well, don't worry. But you essentially just want our fibrinogen forming to fibrin, because fibrin is actually what is going to stabilize the clot and is actually also insoluble. So initiation, after your kind of primary hemostasis, so that primary platelet plug, you have the initiation of the coagulation cascade. Actually, in real life, or when you cut yourself or whatever happens, trauma that causes you to bleed, this happens simultaneously as your platelet plug is happening. So thrombin, which is also known as factor 2, is formed, and it's kind of along with the platelets and the von Willebrand's factor, it forms a complex with factor 8, which is important. The important protein that, as we can see here, von Willebrand's factor brought to the site of injury. And from here, it forms this complex and it activates downstream factors to activate. This then creates more thrombin, and then that thrombin makes more, kind of activates additional clotting factors and more platelets. So it's kind of going that back and forth. And then from there, once all our coagulation cascade proteins are kind of activated, we then have this point where thrombin can cut fibrinogen, which is a polymer, a big kind of chain protein, into fibrin, so smaller things. And as well with this factor 8, it allows for these cross links to be formed, which stabilizes this fibrin and kind of creates a really solid clot that stops the bleeding. So this is just an overview of the coagulation cascade. Everyone always is like, you should memorize the coagulation cascade. I actually don't really think it's important. I think it's more important to kind of understand what's happening. Main things I'd say is that most of these coagulation cascade proteins, so these factors, are made in the liver. It's actually really important because you can imagine if you have a liver pathology, you also get issues with your platelets. Chronic liver disease can cause like thrombocytopenia. But also if you have liver issues, you can have lots of bleeding risks, which is important. And all of these proteins are essentially inactive. And once they're cut, they become active and then essentially activate something else. Definitely know that the vitamin K dependent factors, so these are your TV channels, your 2, 7, 9, and 10. And essentially, regardless of if it's an intrinsic pathway or extrinsic pathway, regardless of what coagulation cascades proteins or factors are activated, the end result is this unstable fibrin clot. So let's just go through this. I think you can see my mouse here. Sorry, it's just on my second screen. So we have our intrinsic side here, extrinsic here, and in the end, it all comes together to form this common pathway and ending in this stable fibrin clot. I think this is a slide I've taken from PS Papa, I want to say. They've kind of got a good couple mnemonics to learn. So essentially you have your 12, 11, 9 with 8 going to 10, or your extrinsic, so tissue damage causing 7 with tissue factor, which I think is number 3, going to 10. And then the common is 2, 5 with your platelets and calcium. 2, 1 stable clot. Trying to think if there's anything else. It looks a bit complicated and doesn't really make you like, what the frick is happening the first time you look at it. But I think maybe just like kind of familiarize yourself with it. The main kind of understanding is that you can have either damage from within the blood vessel or outside of the blood vessel, which causes a different way of getting to the same thing. So it doesn't matter if the bleeding started from within the blood vessels or with the outside of it. The main thing you have to do is form the clot. So that's why we have this. Kind of why they've made it this way is that we can then monitor specific parts of this pathway to see where the if we have any issues with our bleeding, where the issue can be localized to through specific findings. So as again, we have our intrinsic pathway, and this is from your contact activated. So activated by the damage within the blood vessel. And then you also have at the same time or independently the extrinsic pathway, which is activated by the damage to the tissue. And regardless of the initiating event, the same outcome arises, which is your cross-linked fibrin clot. I am going to, yeah, cool. Here, this is another way of demonstrating the coagulation cascade on this nice diagram. But this one looks really confusing, but I actually like this diagram the most. This one's nice and put up into the intrinsic, extrinsic, final common pathway, but this one I think does a really good job of showing how the actual pathway is regulated. So you can imagine, as I think I said earlier, you can't have too much bleeding and you can't have too much clotting. So this has to be a regulated process. So what's really cool about the coagulation cascade is that there's actually within the initiation of the coagulation cascade, it also activates regulatory proteins, which make sure that this process doesn't get out of hand. And either enough thrombin will be formed that it proceeds to a clot, or if not enough thrombin's made, the clot actually will never form in the first place. So here we can see that, as I said, we're trying to get this fibrinogen to fibrin, and thrombin is a really big player of this process. And again, we have our factor VIII, we have our intrinsic pathway, our extrinsic pathway. But we can also see, so we can see here how thrombin's further activating factor V or factor VIII. But we can also see how thrombin activates this thing called protein C, thrombodulin, but this whole complex here, assisted by protein S, which forms activated protein C. And activated protein C has a really important role of inhibiting factor V and also factor VIII. And what's important about this is once it inhibits these factors, it therefore can kind of dampen the response. So we don't have as a significant clot formation as before. So that there's times where protein C actually inhibits the progression of a clot formation, which is actually really important because we know people who have don't have protein C are at a much increased risk of having spontaneous clots. Also, that we have this antithrombin, which is important because we will touch on this in our in heparins, which is essentially heparin's mode of action. But antithrombin 3 is another thing that's incorporated into your clot and part of just your blood. And this kind of inhibits factor 10 and also thrombin. Now, all of these factors, as I said, you have to reach a specific plasma concentration in order for enough thrombin to be caused for this cross-link. So these antithrombin and also protein C and in turn protein S, because protein S activates protein C, these allow for the ability for some form of regulation within this cascade, and it's quite important. So we don't just randomly form clots everywhere in our body. Also, as well as once we've formed an actual clot, we have to be able to break it down. So this is the breakdown process. Essentially, we have our insoluble fibrin, and plasmin is what breaks down fibrin. So plasmin is activated plasminogen, and plasminogen is once we've formed our clot, plasminogen is actually brought into our clot. Over time, we have rising levels of tissue plasminogen activator, or TPA, which is released from surrounding endothelial cells near the site of injury. And this will reach a critical concentration and allow the activation or the cutting of plasminogen to plasmin. And once plasmin's activated, it'll allow for fibrin to dissolve or break down fibrin. What's important about the breakdown of fibrin is that not only does it dissolve the clot, but it also allows for the release of lots of fragments. And an important fragment is a D-dimer. This will become important when you do learn about like DVTs and pulmonary embolism, because it's a marker of clot breakdown. It's not necessarily specific to clot breakdown. You can have rise D-dimers in states of like inflammation, but essentially a D-dimer indicates that a clot has been formed and has broken down. That is kind of the overview of our chat on the general mechanism of hemostasis and thrombosis, so clot formation and clot breakdown. And now we've got our coagulation study. So it's all well and good that our body can do all this stuff, but it's also important that we can regulate what's actually happening. So we have all these, our coagulation studies. So if you order a coagulation profile, you'll be getting most of these studies. If we take a look at our prothrombin time, so this is what measures the extrinsic pathway. So let's go back to here. Your prothrombin time measures all of your intrinsic pathway, as well as the common pathway speed. I always remember prothrombin time, or your PT, as we like to say it, as they call it, as almost a PT, so someone external motivating you. So that's how I remember, and it's the extrinsic pathway. We'll touch on this point in a bit, but INR is what we use for warfarin therapy. And essentially your INR is a internationalized prothrombin time. But if you're trying to measure the extrinsic pathway, you wouldn't say INR. INR is specific only for warfarin. We then have our activated partial thromboplastin time, which is your APTT. And this manages it looks at your intrinsic cascade. So we go back to the photo, it's looking at this part here. Some people also remember the difference between your PT and your APTT, as PT is play tennis, people play tennis outside, so extrinsic, and APTT is table tennis for the double T. And you play table tennis inside, so this is intrinsic. We have I've got a note here, a prolonged APTT is the result of a deficiency of any of the intrinsic proteins. And again, obviously that makes sense. And that would be the same as well for your prothrombin time. Your thrombin time just looks at how well, it's essentially a measure of just the common pathway. So how well does that thrombin allow for the cleavage of fibrinogen to fibrin? So that's looking mainly at thrombin and a couple of those other factors. So let's say you do a coagulation study and you've got some weird results. So perhaps you have something that's going to increase your bleeding time, but you're not actually sure if this is because you don't have a specific protein, or perhaps you have a certain antibody that's activating an inhibitor of this coagulation cascade. So that's when we would do a mixing test, only after our initial kind of profiles are abnormal. Essentially what they do is they take the patient's blood and they mix it with a normal plasma, so a plasma that has all of the coagulation factors. If there's a deficiency, so you take my blood, I don't have factor VIII, let's say, and I put it within the normal plasma, it should normally clot because there's nothing inhibiting the clotting process from happening. Rather, it's just I'm deficient in a specific factor. So once I replace that factor with the normal plasma they add, the clotting time should have resolved back to normal. However, if I have an inhibitor, it doesn't matter how much normal plasma you put in. Eventually, if you put enough, you might be able to overcome because you just have the ratios kind of dilutes the inhibitor. But essentially, the inhibitor with the normal plasma will still not allow for that mixing time to be prolonged. The inhibitor will make sure that the bleeding time is still prolonged because it's not actually, because it is inhibiting factors, that coagulation cascade from eventuating. Also, I have been saying bleeding time. Bleeding time is actually specific for platelets. This is, if you're mixing blood with your protein, with the coagulation. So if you're mixing your blood, the patient's blood with the plasma from that's been derived specifically. Also, we have our D-dimer assays, which are essentially just measuring how much D-dimer we have in someone's blood. And it's essentially, as I said before, indicates that you've had some form of intravascular coagulation, but it's not necessarily specific. And there's times where it will increase as well. This is, I think, a good summary of our coagulation cascades. Just looking through, so prolongation of your APTT. So we have our TT, what people remember as table tennis, so intrinsic, and this makes sense. You're going to have a deficiency of those specific factors that are part of the intrinsic factor, intrinsic pathway. Prolongation of the PT with normal APTT. This means that you have a prolongation of your extrinsic cascade, which is a factor 7, because that's the main factor of that extrinsic pathway. If you have a prolongation of the PT and the APT at a normal thrombin time, so this means that your actual common pathway is fine. It's an issue within your PT and APTT. So that could be deficiencies of your factors that are part of all those pathways, except for the thrombin time. And the prolongation of an APTT, a PT, and a thrombin time is the quite specific for heparin therapy. I don't think it's important, the presence of a complex or deficient state. Heparin therapy prolongs your APTT, your PT, and your thrombin time because of its actions on antithrombin. This over here is just a bit more specific to other things and some other causes. I don't think you have to know anything really about liver disease and bleeding this year. I think just know that if you have a liver issue, it makes sense that you would have bleeding abnormalities because of where all our coagulation cascade proteins and things like that are made. I've got onto some pathologies. I'll just briefly touch on these. I don't think it's actually that important that you know the disease states. I don't think you're necessarily tested on this. This is more a year 3 thing. Von Willebrand's factor, essentially you don't have that circulating, or you have reduced levels of that circulating protein, that von Willebrand's, that big one, which delivers factor 8 and also it helps establish that primary platelet plug. For von Willebrand's disease, you're going to have more of your platelet-like symptoms. And those are things like kind of very superficial bleeding, your petechiae, and perhaps some excess bleeding, like if you are menstruating or post-surgery. The more important perhaps thing to know is haemophilia. I think they did actually ask us, someone has haemophilia B, what factor are they missing? So I would just remember factor A, you're missing, or you've got deficient levels of factor 8, and so haemophilia B, you have deficient or missing levels of factor 9. I just remember that as AB and then 8, 9, sorry. So just going up in order. Important about haemophilia is that the gene actually for these proteins are X-linked. So mainly they're seen in males because they have the XY, and women are able to usually suppress one of their, if they have a X-linked genetic thing, they can suppress the kind of bad gene. The main thing about haemophilia as opposed to von Willebrand's factor is you're going to have more kind of serious bleeding issues. So you have these haemophillia, as we can see in this picture here. Those knees aren't actually swollen due to trauma, but actually they've had bleeding into those joints, which is you have these spontaneous bleeds, like they could be in bed for the whole time and they've just bled into their joints. This is where you would have your prolonged APTT, which actually corrects on the mixing. So once you add the factors that they're deficient in, their bleeding times are normalized, or the coagulation panel is normalized. And management is essentially just give them the factors that they're missing. As I said, not super important to know the pathologies, maybe just I would know a kind of brief overview and also what I've highlighted here. This is where I'd say kind of the juice of this, the most important things and also the most clinically relevant things to know, because antiplatelets and anticoagulants are important in so many conditions, from your cardio to breast, obviously your hematology as well. And essentially every single patient almost in hospital is put on some form of anticoagulation to prevent a DVT as well. So they're very, very common medications. Starting with our antiplatelets, the drugs at the bottom, I wouldn't necessarily know at all, but aspirin 100% learned. So I've got on the right essentially an overview of how the antiplatelet aggregation begins. So you can imagine that when we inhibit certain steps along this, you're not going to allow for the formation of platelets and the primary platelet plug. So if you stop that, you stop the platelet aggregation. In all of these antiplatelets and anticoags, I just try and really understand the mode of action. And if you understand why and how the mode of action works of specific drugs, you'll also be able to understand, or you'll know that you understand also the whole kind of primary hemostasis and a secondary hemostasis as a whole generalized concept. So aspirin is actually a COX inhibitor, but it inhibits that, which then inhibits the formation of thromboxane, A2, which is TXA2. I think they actually asked us in our exam, or maybe it was in one of the practice exams, which specific one of these drugs inhibits thromboxane. And so that's what aspirin does. And then that inhibits the ability for platelets to recruit and kind of aggregate and form that primary platelet plug. All of these anticoags and antiplatelets the indications aren't going to really make that much sense to you. Just know from the antiplatelets that you'd give it to someone who maybe had increased risk of having a myocardial infarct, so a heart attack, and you usually give it post someone having a heart attack. Lots and lots of people are on aspirin. The next kind of important antiplatelets to know are your P2Y12 receptor inhibitors, which are your clopidogrel, ticagrelor, and together, if you have someone on dual antiplatelet therapy, they're on a P2Y12 inhibitor, as well as the aspirin here. So these drugs inhibit the ADP-induced activation of platelets. We can see on the right, just over here. And they're essentially doing the same action as aspirin, just on the other side. So they're still inhibiting this and decreasing this phase here, the platelet recruitment and activation, to then stop the platelet aggregation. For these, I would know that you would give them mainly post someone having a heart attack and after they've put a stent in. I think that's also probably too much. The yellow is the most important thing here. So these are your antiplatelets that I would know. You can come and learn this, what I put in small, the apiximab, which is essentially just an IgG antibody. And it goes against this G2B3A, which is a small kind of receptor, which activates platelets and then furthers kind of the hemostasis, but I haven't seen that used as much, and the main kind of clinically relevant would be aspirin and your P2Y12 inhibitors. And this works as well as with the ADP. Cool. Now we're moving on to our anticoags. Warfarin's the classical anticoagulant, and it is a vitamin K antagonist. Warfarin is a bit of a tricky drug because it actually it makes sense that it's a vitamin K antagonist, so it's stopping the ability of the liver to make specific drugs that are factors that are out of that use vitamin K. So our TV channels are 2, 7, 9, and 10. But the thing about warfarin is that it has lots of contraindications, and also it has lots of it like interacts with a lot of medicines, and also some people just naturally, like some leafy vegetables, I think it is, increase kind of its potency. And also you have to make sure that they're in the specific dosing range, which is what we use our INR for, which is essentially just our PT normalized for warfarin. And if you are to put someone on warfarin, you have to monitor their INR to make sure it goes into that specific range of, I think it's like 2 to 3. And you can't have it in pregnancy because it's teratogenic. But you also have to do something called a bridging therapy with warfarin, because initially it makes you increases the likelihood of you clotting if you start on it. And obviously that's what it's trying to stop. You would mainly give warfarin to people who have specific types of atrial fibrillation. The new kids on the block are these things called the NOACs. So NOACs are your novel oral anticoagulants. And these are made up of your factor 10 inhibitors and your direct thrombin inhibitors. All of the anticoags here I would learn, both warfarin and your NOACs. So your factor 10A inhibitors, you can imagine it stops factor 10A from being activated. And then that kind of prevents the formation of a clot. And then your direct thrombin inhibitors stops thrombin, so it also stops the potentiation of that whole coagulation cascade. These are also given in things like atrial fibrillation. The benefits of DOACs over warfarin, DOACs is the same as the NOACs, I put this in the speaker notes, is that you don't have to dose these things to make sure that they're in the correct INR range. They're safer for people who are pregnant. They also have less drug interactions, and they usually have the same efficacy and as warfarin, but actually a almost better bleeding risk profile. And you also don't need that specific diet modification. People on warfarin have to constantly be going to getting blood tests to monitor their INR. So if you don't have to do that and you're just on the DOAC, it's much better. Just easier for the patient as well. This is a bit blurry, taken from, I think it's Vespar's, and a great summary table of the differences of all the anticoags. Here we're about to go into our heparin, but yeah, important to note is our antidotes. So one of the disadvantages of the NOACs over warfarin is that the NOACs actually don't have any antidotes. So warfarin, you can give someone vitamin K to kind of reverse the effects of warfarin, because you can imagine on lots of these anticoagulations medications, as well as the antiplatelets, you're at an increased risk of bleeding. So if you're taking warfarin, you fall over, hit your head, you're at an increased risk of having a brain bleed. So if you present to emergency, they're going to try to reverse that. But the NOACs don't actually have a reversal agent. Moving on to heparin and enoxaparin. Every single patient in hospital is on clexane, so enoxaparin, which is a low molecular weight heparin. That's just the bottom drug. Heparin essentially binds to antithrombin 3 and increases its activity, and antithrombin 3 was one of those, it's own regulators of the coagulation profile. Heparin, one of the benefits of heparin is you can actually use it for pregnancy. Maybe I said that you can use the DOACs for pregnant. If you're pregnant, you can't. Heparin is what you would use. You have to give this either IV, so you give a heparin infusion, or subcut, and this is usually someone comes in with a heart attack, you'd give this. Essentially, it is also a natural product, and it does have an antidote of protamine. Enoxaparin is just low molecular weight heparin, and instead of inactivating thrombin as well as factor 10, it just inactivates factor 10 by increasing the activity of antithrombin 3. It has less impact on your platelets than heparin. So essentially, instead, a heparin can cause thrombocytopenia. Clexane is less likely to do that, and it's usually just an injection. You would give these to decrease the risk of someone having like a DVT while they're in hospital. The one downside of Clexane is that it's renally cleared, and that's really important in people who have kidney issues, in that you can't give them Clexane because I think it's an eGFR of less than 30. It's actually going to be sticking around too long, and then they're at an increased risk of spontaneous hemorrhage, which you can imagine is not too good. Now on to our last slide, and kind of the reverse coin of the anticoagulants is your fibrinolytic agents. So you've had the clot and you're trying to remove the clot as quickly as possible. And essentially we use these in things like a ischemic stroke. So when you have a clot in your brain, or a heart attack when you have essentially a clot in your coronary arteries. Essentially, tranexamic acid, I don't even think really important to know. It's just if some people have really heavy menstrual bleeding because they might have, for example, a von Willebrand's factor disease, or they might have platelet issues there. I think the main one to know is alteplase. And this is, again, is a drug that I would learn. Essentially, alteplase is recombinant human TPA. So it's essentially tissue plasminogen activator, which allows, kind of catalyzes that conversion of plasminogen to plasmin to allow for the fibrin breakdown. And you give this IV, and it's very important in times of someone having a clot. And you can imagine that the you're trying to increase the perfusion to these areas. So you want to give it as fast as possible. And your adverse effects would be your bleeding and internal bleeding. I have actually made a mistake here and said hemorrhagic stroke. So that would be a contraindication to alteplase. So it's not hemorrhagic stroke, it's ischemic stroke that you would give it in. And a hemorrhagic stroke is actually a contraindication, also an adverse effect of giving alteplase. You can imagine with all our drugs that are trying to decrease the risk of clots, increase the risk of bleeding. So lots of people who have bleeding issues, maybe they have increased risk of bleeding because they have like protein C deficiency or factor V Leiden or our von Willebrand's or haemophilia. You would not give these people anticoagulation of almost any kind because that increases their risk of that spontaneous bleeding. That is all I have on hemostasis and thrombosis. I hope that was helpful. Kind of just going on what is important to know. I'd learn those drugs, specifically the mode of action. Don't really need to know the indications for it. And kind of make sure you have a good overview of kind of the different coagulation studies. So your PT versus your TT versus your your PT versus your APTT versus your thrombin time. And yeah, hope that all helps.